Welcome back. You're still watching Daybreak, and it's now 1 minute to 7 o'clock. We've never been here. We never come from a break 1 minute to 7 o'clock. My name is Sam Gituku, and I'm still with Dr. Githinji Gitahi, and now joining us is Dr. Chibanzi Mwachonda from KMPDU. And Dr. let's begin by, you've been telling me something during the break about the state of affairs when it comes to COVID-19, and especially with the flattening the curve. What are your views on what we are seeing now?
I think first and foremost is to say that it's actually a good trend to have seen where we are as a country. But we must also remain alive to the fact that we've seen industrial disputes and industrial unrest in the health sector since December. As we speak, our public health facilities are not operational, and that brings to question the true picture of the test results that we've seen. Who exactly are we testing? Are we testing mostly people who are, one, seeking healthcare in private facilities, two, people who are traveling? And so they need to test, because in reality, in the counties away from Nairobi, Mombasa, most of the public health facilities are not functional. Remember, we had over 68 COVID-19 designated facilities. Not all of them are operational as we speak. At the national level, yes, they are operational. But in the counties, most of them are not operational. And so the Kenyans are not seeking services in these public health facilities. So that also creates a scenario where, are we really testing the people who are also sick? In as much as you take into consideration all the other factors that Dr. Githinji actually alluded to initially.
And that's interesting, because Dr. Githinji had said that when it comes to testing, if you have to look at the positivity rate, it doesn't tell you a different story. So what does, how different would this be? Because I'm not sure you have reported more fatalities even in the upcountry. I could be wrong. And
that's what I'm saying. When the hospitals are shells and Kenyans would seek services here, then even the mortality rate that you'd be reporting out of the patients who are in the hospitals will not be the same. And so what you're seeing is a scenario where there is, the tests, I mean, the research done that showed the antibody testing and a big a section of the population actually having gotten COVID, gives us another realistic approach to this in terms of analyzing the COVID situation in the country. And remember that even the fatality that is being reported is mainly in the facilities that are operational. So where you've not had facilities being operational and Kenyans are dying, perhaps even out of COVID.
Right.
Where are these deaths being recorded?
Dr. Githinji, are you convinced, are you persuaded that we might actually be dealing with an error in our sampling, that our sample may not be as representative as we may have wanted?
I wouldn't actually think so. And, you know, in terms of, let me take a step back. When we started this, I was concerned about community deaths that may not be going to hospital. And that was way even before, when we started around March and April. And I remember going out some of the counties to check whether we had excess deaths in the community. Because remember, Sam, that a death in the community is not recorded in the hospital. It is recorded by the police. So we already have a dichotomy of data there, which we had raised concerns that needs to be addressed, because we need to have a common register of those deaths. But the Ministry of Health may record only those deaths that happen in hospitals. So in a way, what Dr. Chibanzi is saying has value in looking at it that way. On this other side, we know that we have thousands of people are being traced. Yesterday, I think the day before, when I saw the report, we had about 2,500 people contact who are traced. So we are still tracing, because remember that COVID-19 is as much as a community issue as it is a facility issue. So if it's a community issue and we are actually tracing contacts and testing them, you'd expect those contacts who are traced and tested to reflect, at least to some extent, the rate of transmission in the community. Because if you get 3,000 people and you test them, and because they are contact, therefore they are high risk, you would expect to see, you know, a true picture of the positivity rate. Right. So I would say that on the side of mortality, we need to be more careful, because we may have community deaths. As we had even before the industrial strike, we had community deaths that were not recorded. and that is an issue of the way we record our deaths. On this other side, if we are doing contacts, we would expect to see at least the trend lines, even if not the headlines. We would expect that over time, if the infection is spreading, you'd expect to see the positivity rate going up with the samples of people who are contact traced and tested.
All right, and we still have two more issues to pursue during this discussion, and let's now focus on the variants that are being reported in different parts of the country. I don't know, from your experience, I will be playing a clip of Patrick Amoth shortly on these variants, but the information I have is that so far the UK and South African strain have been reported. But Dr. Chibanzi Mwachonda, how much have you heard from your colleagues, and how severe are these new strains, and how difficult will it now be when it comes to containing this pandemic?
I think the issue of new strains is something that, yes, we do have the strains in the country, but with regards to how rampant is it, the rate of infection within the community or within our country, it's a matter of watch and wait as we speak. I mean, January, February, and now that we're in February, perhaps in the next 2 or 3 weeks, we'll be able to tell really where we are, and perhaps even in the next month or so. So as we speak, it's not a very absolute picture of this issue of the variants in the country. Yeah.
Right. Do you have the clip of Patrick Amoth? Right. Let's listen to the Director General.
Of these three, we have picked up the UK variant, which was picked in December last year, of some 2 tourists who came from South Africa who were entirely asymptomatic. We did genomic sequencing through our lab in Kilifi, and we picked the South African variant. We did contact tracing of the people who were in close contact with these 2 gentlemen, who have since gone back to their country, and all of them turned negative.
Right, and Dr. Githinji, South Africa is dealing with that menace because, yes, they have received some vaccines in their country, but they're now having to suspend the AstraZeneca vaccine because of this variant that they say appears to have just 10% of, a very minimal benefit to stopping this variant and also the effects. How does this complicate the strategy of vaccinating these populations, especially in the African region?
You know, the experiences we are getting from South Africa and from vaccination and the new variants remind us the need to ensure that everyone accesses vaccination in the fastest time possible, because the new variants are appearing because of us leaving the virus to actually just operate in a wild manner within the populations without vaccination. So the longer the virus stays in us, the more mutations we are going to see. Remember, Sam, that mutations of viruses, especially this type of a virus, which we call the RNA, are very rapid and many. And therefore, we don't know all the variants. There are hundreds of them and maybe thousands. What we are concerned about is what we call variants of concern. And variants of concern are those that, number one, may increase the infectivity of the virus, as we've seen with both the UK and the South Africa one. Secondly, may increase the severity of the disease. None of them has been confirmed to be more severe, but of course, if you have more people infected, you're more likely to have more people needing hospital. And the third thing is, if the virus's mutation changes the way they're diagnosed, meaning we have to start doing new tests to find out new viruses. And finally, if it helped the virus to escape the vaccine. And that's what we are seeing doubts of, that actually, if the mutations change the structure, that therefore the vaccines do not work, then you have to worry. Now, I don't think that the evidence in South Africa is conclusive. We hope it's not. And we would hope that, from what we've heard before, is that the vaccines that are available have been seen to still have adequate protection against the new variant, because because of the way they are made, they are actually made to stop the virus from increasing the severity of the disease. They're not being made to stop the infection. They're being made to stop the severity of the disease. We've seen great success in Israel, for example. Israel has been using the Pfizer vaccine. I have seen that after vaccinating a big percentage of their population, up to about maybe 40–50%, we now have 40% reduction in infections. We have about 30% reduction in hospitalization. We have about 20% reduction in deaths. So you can, from those who are severely infected or severely ill. So we know that vaccination works, and even where it's been used in mass population, other than the lab and clinical trials, only evidence, we know that the vaccines are working. And we'd hope therefore the evidence in South Africa, because they just started vaccinating very recently. We'd hope that that evidence is not conclusive.
Right, and they're saying, let me just quote a story here on CNN, says that the study which has not been released included about 2,000 volunteers who are an average of 31 years old, and about half received the vaccine and half received the placebo, which does nothing, obviously. And now they're saying that it appears that the vaccine is not able to stop the mild to severe infections or complications. But Dr. Chibanzi, what have you been hearing from your colleagues when it comes to preparations for a nationwide inoculation program? Because the Ministry of Health tells us that they are expecting, is it some 24 million doses by, is it mid this month? So it's in about 7 days' time. What have you been hearing on how prepared we are?
I think the whole issue of vaccine, and we must be prepared, and yes, it's good that we've seen the effort by the government and the Ministry of Health to secure vaccines through the AU platform, where we had over 24 million doses, and then the plan to also procure over 12 million doses. So we're looking at almost 40 million doses of vaccines. But there's one thing that I think is where, in as much as vaccines are coming, that the country and the ministry really needs to work on vaccine hesitancy, because there's a lot of information about the vaccines, misinformation, and that this is going to be a real challenge. And this challenge is not only in the population, even in the health sector where you have healthcare professionals. The hesitancy issue is one that really has to be dealt with and really approached in a manner that will then see us, we don't want to be in a position where there are vaccines, but then the uptake of the vaccine is also very low. Yeah.
Right, and Dr. Githinji, you might know what strategy it is, because like he says, there are those people that is it being mythical, that they say this is intended for certain outcomes, or maybe this is just a plot by the government to do some conspiracy, all those conspiracy theories. So how do you communicate to the public to ensure that, yes, there's the uptake, but also there's fair distribution of this very important weapon in battling the pandemic?
There are several layers there. The first layer is that you have to give information at every point. So as Dr. Chibanzi is saying, it is true we have a fair level of hesitancy. I think the last time I checked, there was a study done of about 15 countries by the African Union and through Africa CDC, and Kenya was said to have about a 14% hesitancy rate, 14%, and it could be worse in different cohorts of people. You know, as he says, we don't want health workers to have hesitancy because they're the opinion leaders to the people. We want them to actually be the ones giving the information, the correct information, and when they have hesitancy there, then there's a danger that the flow of information to the public may not be as intended. So the first thing would be give information and give that information continuously. Secondly, address people's concerns through what we call frequently asked questions. We know what people are asking. We know those questions, and therefore they need to be addressed urgently. Third is engage the people who are closest to the people, religious leaders, community leaders, local leaders, women groups. Address it there. Don't address it in a national address and say, don't worry, this vaccine is okay. It is okay. We know it's safe. We have seen some safety concerns somewhere, but that's out of, like every vaccine will have safety concerns, and that's why we monitor what we call adverse events even when you are administering. So then kill the myths and misconceptions. There's a lot of misinformation and disinformation. You have to go out to clear that, again, through the same channels of ground up, not just making national announcements.
Right.
Finally, in terms of access, as you've asked, is to ensure that the vaccine is free. If you have to make sure it's accessible to everybody, then you need to make sure that that vaccine is free. We know vaccines are free in Kenya. Majority of vaccines that are given through the National Immunization Program are free, and we are getting free vaccines from the COVAX facility, about 24 million doses, and we have seen that some are going to land here maybe by March. So again, make sure they're free. they're accessible, and you're using the channel that everyone can access. Of course, remembering that we are starting with particular priority groups, health workers being one of them, and then going on to the vulnerable people, the elderly, people with hypertension and diabetes. So that's the way to assure access. But on hesitancy, it's about information and using the right channel that people trust.
And why would medical officers, the doctors themselves, have such a difficulty? Yet they've gone to school and studied this. What do we do to make them comfortable?
You see, at the end of the day, for the healthcare workers, what healthcare workers are looking at and having information, a lot of information around vaccines and the issue of adverse events, then what you see is also amongst the healthcare practitioners is that thinking that what if I fall on the side that actually gets into the adverse events? And that becomes a key area of concern. And that would only take a lot of not just reassurance, but also a scenario where the uptake has to be from the leaders, as Dr. Githinji said, and also to make sure that they're assured in case of any form of event that then they will be taken care of really well. Because you can imagine if the health practitioners do not take up this vaccine, then it will be very difficult for the public to take it up. And then another section of leaders that will actually also have to come out and convince the public more so than the healthcare practitioners is our political leaders. And we've seen that happening in various countries in Europe, in the US, where political leaders have actually taken up the vaccine publicly. That is one area that will also help us in terms of dealing with hesitancy amongst the general population.
Right, and Dr. Githinji, there's something you referred to, back to the variants, and you said that the mutations may lead to changes in how the virus is being detected. I'm just curious, because the past 1 or 2 weeks we've seen the very intrusive way of detecting COVID-19 in parts of China. Should it get to this?
Not at all. I think what you've seen on China is not a change in the method of detecting the virus. It is a change, it's kind of test on new ways of collecting the sample. Those are very, very different. So you can collect the sample in many ways. We know that right now we do an nasopharyngeal swab, an oropharyngeal swab, but you can also, we've seen states that use sputum, for example, the others that use saliva. Now we are seeing the antigen tests where you take, you use a rapid antigen test. So the test is the same because the virus is the same. You're looking for the RNA. That's what you're really looking for, the RNA. And that is not changing. What you saw in China is a change in how to collect the sample. And, scientists will try everything. It may not be that it is the most effective and therefore that's the way to go. But scientists will try. That's why we grow, because scientists try different things and some work and some don't. So I don't think that was a large-scale scientific change. It was that, you might find more viruses if you know an anal sample because people are swallowing, probably. That's why you're finding the virus in anal samples. It's not a large-scale change in the way the virus is detected.
Okay, all right, and I want us to spend the remaining few minutes to discuss about the impact of COVID-19 in as far as improving our facilities. And Dr. Mwachonda, of course, you've been at the forefront in fighting for the rights of doctors, specifically from your union. But when you look at how we have improved our facilities, remember that at the start of the pandemic, the governors and the national executive were saying that they're investing in improving the ICU capacity, the hospital's capacity. Have we done such a good job that you can say even after the virus, after COVID, then we have very well-running hospitals?
It's fair to say that there's been significant improvement in terms of the infrastructure, in terms of the testing, improving our labs, for instance, to be able to test COVID-19, because this is a PCR testing. And PCR testing is not just for COVID. We test so many diseases using the PCR test. We did see a significant improvement in trying to ensure that we have enough isolation and treatment centers. We've seen significant improvement in ICU capacity, but it's not been as optimal as where we should have been, or taken the opportunity and actually run away with it, because this is actually an opportunity where we should have actually strengthened our healthcare system to a level that even after the pandemic, we do not really have to still struggle with ICU space. But it's work in progress, I'd say. We have not really taken it to where it should have, but there has been some significant improvement.
A significant improvement, you call it. And Dr. Githinji, so now the universal health coverage, does it remain still a dream, or has COVID-19 helped us get or inch closer to that dream? And what do you think needs to be done in the coming days and weeks and months?
Universal health coverage is a combination of on one side, availability of quality services, as we are discussing here, looking at availability of optimal health workers, and health workers is not doctors here, it's doctors, nurses, lab technologists, community health workers, all the cadres that we require. Are they optimal, and where are they? So there is a health system issue. Health workers, availability of facilities, which Kenya has a fairly good distribution of facilities if you combine both private and public. And private also means faith-based organizations, because they also play a part. It's one health system, not just public. So you look at that infrastructure, it's not too bad, unless in areas like in the northeastern where we know that there is actually sparsity of health facilities, and we as AMREF have actually had to use camels in some of those areas to deliver commodities to pastoralist communities because the health facilities are too far, or set up container clinics where the people are traveling to because the health facilities are too far. So we know there is an equal distribution of health facilities. That must be addressed. The next one is availability of commodities and the proper availability of quality commodities. And then there's the issue of data that we need to also make sure we are able to get our data in the health system. We talked earlier about community deaths. That is lost data. When they are reported to the police, when somebody dies in the house, and the health facilities or the health sector doesn't know, we don't have adequate data to determine our decisions and our investments for the future. So this is a health system issue. This must be done. But then the next question is to ask, when this is done, how do people now access what we have built, what we have constructed, what we have, the health workers, all these decisions. And that is the big issue of universal health coverage. How do people afford health care? The movement that we have seen is the government saying, let us start looking for the poor and covering them, giving them free NHIF cover. Even as we now try to build up NHIF cover, can we ensure all the poor have access and the government pays for the NHIF card for all households who are poor? Because now the big question is about financial affordability. UHC is all about the fact that health costs, when they are not managed, will make people poor through selling their cattle, selling their land to pay hospital bills. That protection of what we call financial protection, is what we are moving towards. So I've seen some positive move, good investments in the health sector, as we are saying, not adequate, not optimal, but some good movement. But we've also seen accelerated efforts to ensure that the poor have subsidized NHIF cover, and I hope that is taken to its logical end.
Right, Dr. Githinji Gitahi, Dr. Chibanzi Mwachonda, I wish we had more time because there are still many things that we need to speak about, including the Building Bridges initiative. And I know you never thought you'd ever have to discuss that, but it is important because 35% of resources will now be devolved to the counties should that document become law. So we'll spend some other time to focus on that and what should be the priority areas for the county governors and the country at large. Thank you so much for your time. Up next, we speak to Honorable Martha Karua, who is the NARC Kenya party leader. She'll be speaking to us about the state of the nation and starting all the way from the Building Bridges initiative up to the political intolerance that we experience in the country and what should happen as we walk the road to 2022 politics at a time that those hostilities are already being reported. After the break.